Real news for Americans 50 plus. This is Emeritus News Channel.
Good afternoon. What we'd like to do today is to tell you what we know and what we don't know about what's happening with H1N1 and what's happening with vaccine preparations and production. What we do know is that H1N1 is spreading widely throughout the U.S., particularly in the southern states, but in most of the country, H1N1 activity is now widespread. We also know that so far there's been no change in the pattern of disease. So most of the people who've become ill with H1N1 have had disease similar to disease in a normal flu season, moderate illness. It has affected disproportionately young adults and children, people ages 5 to 24. And although people sometimes think of the flu as a mild illness, in fact, having the flu is no picnic. Even in an average case, it can knock you flat on your back for a couple of days. You can miss school and work, have some difficult days, and in severe cases, it can put you in the hospital. And tragically, some people have died with H1N1, and we will inevitably see deaths in the future. Our challenge is to minimize the number of people who become severely ill or who die from H1 influenza. So far, the laboratory studies show that there has been no significant change in the genetic makeup of the circulating H1N1. That's really good news. It means that the vaccine that we have coming off the production lines shortly is a very good match, in fact, an excellent match with the virus that continues to circulate, which suggests that it's likely to be highly effective at preventing illness. It also suggests that so far the disease is not likely to become deadlier. But what I'm going to describe is first what we know and then what we don't know. We know a lot about what's happened so far. We can't predict what's going to happen in the future. Influenza is perhaps the most unpredictable of all infectious diseases. We know that although millions of people have gotten sick with H1N1, the overwhelming majority of them don't need testing or treatment. However, if you're severely ill, such as having trouble breathing, or you have an underlying condition like heart disease or lung disease, diabetes, women who are pregnant, it's important to get treated promptly because treatment in the first 48 hours is most helpful. That's a challenging message because it means that on the one hand, we're encouraging people to contact their doctors or do self-care in most cases, but in certain cases to get care promptly. One of the real challenges about dealing with H1N1 influenza this season. We also know that there is plenty of Tamiflu, oseltamivir, available. And although it's important that it's used carefully, people who need to be treated are people who have underlying conditions or who are severely ill. It should not be used generally for prevention, and it should not be used for most mild average cases of influenza. That way, people who really need it will have enough to go around, and we won't have as big of a risk of resistance, because resistance we know does develop, so we have to preserve that drug for when we really need it. We also know that although we've seen widespread disease, we've seen relatively few school closures, and that's consistent with what CDC recommended last month to minimize the disruption to learning and to communities when H1N1 is present. Common sense measures can reduce but not prevent the spread of influenza. The most important is to stay home if you're sick. If you have fever, stay home for at least 24 hours after you have no fever when you're off all fever-reducing medications. Also, of course, cover your mouth when you cough or sneeze and wash your hands frequently. Those are some of the things that we know about influenza. There's a lot that we don't know as well. We don't know, and only the future will tell, if H1N1 influenza becomes more deadly in the weeks and months to come. We don't know whether the fact that it's beginning to trend down in some areas suggests that it will completely go away in those areas. We don't know if it does, whether that will be over weeks or months. And if it does go away, we don't know whether it will come back this season. We also don't know whether we will have another flu season. The other circulating flu viruses, such as H3, are present still in many parts of the world. And just because we're having an outbreak of H1 doesn't mean we won't have an outbreak of H3 later on this year. Only time will tell. So the basic take-home messages for those of us in public health and healthcare are to monitor intensively to see whether the virus is spreading in different ways, whether it's becoming deadlier, and to be ready to adjust our approach if it does. And for the public to stay home if you're sick, cover your cough, wash your hands, and if you are at risk of serious illness and become infected or ill, to get treated promptly. And as soon as vaccine becomes available, to get vaccinated. And that brings me to what we know and don't know about vaccine. Vaccine is by far our best tool to prevent influenza. It prevents both the spread of influenza and serious illness from influenza. We know that the new H1N1 vaccine will be available in significant quantities by mid to late October. And we know that some vaccine will be available before then. We know, more good news, that a single dose is quite protective of people aged 10 and above. And we know that although people understandably have concerns about the safety of vaccine, that there's every reason to believe that this vaccine will be safe. It is being produced just as seasonal flu vaccine is produced. Last year we gave over 100 million doses of seasonal flu vaccine. It's being made by the same manufacturers, in the same factories, with the same mechanisms, with the same safety precautions as every year's seasonal flu vaccine. And really the fact that it's acting in the clinical trials very much the way seasonal flu vaccine acts gives us additional reason to be confident that there's every reason to think that this will be a safe vaccine. I certainly have no hesitation getting the vaccine, having my family members vaccinated, and I think that's the case for all of us working on the vaccine response. We know that it's particularly important that certain groups get vaccinated, people with underlying conditions, diabetes, heart disease, problems breathing, pregnant women, healthcare workers, people who care for infants, and kids who are in school. And that's one of the reasons why you'll be seeing over the coming weeks school-located vaccine clinics, something we don't usually do in a normal flu season. We also know that seasonal flu vaccine is available. It's in large numbers, more than 50 million doses are in the system. That's more at this stage of the year than in any previous year. And there are lots of myths about flu and flu vaccines which make it difficult to get people vaccinated every year and will undoubtedly make it difficult this year. First, you cannot get the flu from the flu shot. There's no way. It is a killed virus. You can get a sore arm, but you can't get the flu from it. Second, flu is not necessarily a mild illness. Many people who do have a mild viral infection, a cold, think it's the flu and think it wasn't a big deal. Flu makes you pretty sick. You feel bad, and if you've got an underlying problem or you're unlucky, you could get very sick. So we need to take the flu seriously. Also, when seeing a doctor, even if someone has mild illness, they can get vaccinated at that time. Now, the flu vaccination program for H1N1 is going to be challenging. In a normal flu season, with lots of time for preparation, with years, even decades of practice, working with provider groups and others, we vaccinate about 100 million people over about 4 months. What we're looking at now is vaccinating as many people as want to be vaccinated in as short a period of time as possible. And there are enormous logistical challenges to doing that.